Welcome to Doc Discussions with Dr. Jason Edwards, brought to you by St. Luke's, St. Louis.
Welcome to Doc Discussions. I'm Dr. Jason Edwards, and this is, in my opinion, the world's best medical podcast. We're here to have discussions with physicians to discover who they are and what they do. And I'm joined with my good friend, Dr. Sajid Zafar today. Sajid is a gastroenterologist.
Thank you.
How are you doing, sir?
Good. How are you?
Yeah, I'm doing well.
Good.
And so, Sajid, you're from Pakistan originally, correct?
That is correct.
And you went to school at Dow Medical College, which is in Karachi. Yes. Is that correct? And then, now, are you from Karachi originally?
Originally from Karachi.
And that's like the Miami of Pakistan, right?
It is the biggest city. It is on the ocean, and it is the most hustling, bustling, most populated city, more than 20 million people now.
How about that?
And so it's one of the top, I would say, top 10 biggest cities in the world.
Yeah. And I've heard of Dow Medical School. It's a very nice medical school.
Yeah, it is one of those founded in 1945.
Okay. And then how did you make your way to St. Louis?
So after I finished my medical school, I applied for residency from Pakistan.
Okay.
And in those days, you can apply by mail. There was no email or anything. This is 1991.
Okay.
When I applied. And you would get interviews in the mails. So SLU was one of the places who invited me for interview. So I took a flight. And I had other interviews also. Yeah. And about 15 or 20 interviews back then, which was a lot of interviews.
That's a lot of flights.
And it was good times. And so the embassy in Karachi, they would ask for why you want to go there. And you would say, well, I'm going there for an interview. And in those days, I think there was somewhat shortage of physicians in internal medicine. Okay. So they would quite lenient in giving interviews. They would check your scores. Yeah. And if you graduate from medical school in Pakistan. And so we got interviews, got here and did a bunch of interviews. The reason I ended up in St. Louis was one of my wife's uncle. He did his undergrad in St. Louis. Okay. So there was some familiarity with this town. Yeah. And when I interviewed, the interview went well. I liked the program. And when you go through the match orders, I matched other places also. And St. Louis U was my first choice. And the rest is history.
The rest is history, as they say.
So I did my residency here till 95. Okay. And then I worked primary care.
Oh, really?
In a small mountainous community in the Appalachia.
Now, what city was this?
It's called Bryson City, North Carolina.
How about that? So that must be western North Carolina.
Western North Carolina, about an hour west of Asheville.
Is it near Boone?
Boone was not too far.
Yeah.
So Knoxville was about an hour also.
That's a pretty area of the country,
Beautiful.
But very poor.
Beautiful, very poor.
Yeah.
There's no factories there. There's no industry there. I mean, Smoky Mountain National Park, I would say half or maybe more of the town was part of the Smoky Mountain National Park. Okay. So, and then, so we spent 3 years there. Okay. And then I decided I want to do fellowship and applied for gastroenterology and ended up at Columbia, Missouri. At University of Missouri, Columbia.
Sure.
And so Missouri has become home. Yeah. And then in 2001, when I finished my fellowship, I came back to St. Louis and St. Luke's has been the home since then.
Yeah, and
First and last job.
Everybody knows you. You're Mr. St. Luke's. You're a part of the fabric here for sure.
Yeah.
I think that's one of the advantages of having good universities in cities and in states is it attracts highly talented people from across the globe to your city, and sometimes they stay.
Yeah.
And so, and it also, in my experience too, that the people who come from other countries and do their medical training here are typically kind of the cream of the crop. Because
that is true.
They have their pick. And I know your scores must have been good.
Yeah.
Yeah. And so now you're a gastroenterologist. And do you do mostly procedures or do you see patients in the clinic and talk to them about their
both.
Okay.
Both. I mean, procedure is a unique thing about gastroenterology, because we really do a lot of procedures.
Yeah.
I think so. If you really calculate the number of procedures we do, I don't think so there's any specialty which comes closer to us.
Yeah.
Whether surgical specialty or medical subspecialty, because of just the bare number of procedures we do.
And
I mean, anywhere from 1,500 to 2,000 procedures a year performed by a busy gastroenterologist, and some more.
And that's colonoscopies,
endoscopies,
and that's when you go down the throat with the camera,
right? And colonoscopy, the other end, and then ERCPs.
Yeah.
Other procedures in gastroenterologists. So not all gastroenterologists do all the procedures.
Some specialize.
Some do. Some specialize. Some only do that. Some don't do that. So endoscopic ultrasound and anything. I mean, I think so. We can pretty much get anywhere where the scope goes, and we can do a lot of things with a lot of toys and tools through the scope. And we're talking about few millimeter channels, and we just put probes through that and do everything: cutting, stopping bleeding, removing tumors and polyps, and doing a lot of injections. And so all through those probes, we do everything.
And you and I have mutual patients who have gastroesophageal junction tumors or esophageal cancers.
Putting feeding tubes
for people who are having difficulty swallowing, for maybe a head and neck cancer, rectal cancer. And so, and I would say GI probably interacts with a lot of different specialties.
Yeah. I feel sometimes GI should have been a surgical subspecialty.
Yeah, it's somewhere in between, right?
We are somewhere in between. I mean, certainly internal medicine is our foundation. We all have to do internal medicine residency first before you become a gastroenterologist, just because in GI, a lot of people don't know. I mean, we deal with liver, which is a big subspecialty of gastroenterology. Mm-hmm. And that's completely medical subspecialty.
Yeah.
We deal with diseases of gallbladder and pancreas. But a lot of bread and butter just requires a very close interaction with surgical subspecialties. If we diagnose something which we can't fix it, surgeon takes over. And then we can do a lot of things minimally invasive as compared to surgery. A simple example is feeding tube placement, which used to be the forte of surgeons back in the days until we discovered percutaneous method.
And that's really cool for people who have not seen it.
Right. It's a very simple procedure, but it really saves you surgery.
And so quickly describe it, and you tell me where I'm wrong. A tube goes down the throat, and it has a flashlight on the end.
Right.
And you shine it through the stomach, and you can see it through the belly.
Right.
And then you bring...
And that becomes my entrance point.
From the outside
in.
Yeah.
You need to have that good light reflection.
Yeah.
If you don't have a good light reflection, it means you may be hitting another organ in between. And of course, there's been reports of liver in between or colon in between. And so you need to have a good light reflection.
And then it's a pretty slick procedure, really.
Yep.
So
you feeding in, and then and removal is also very easy. If you don't need it after that, just come to office. We just gently pull it out.
Yeah.
And so it can be very helpful to the people who has a good indication.
Yeah.
Person with radiation esophagitis, head and neck cancer.
Yeah. Sometimes the cancers get so big in the head and neck area that they can't swallow.
Exactly.
And so that's a shortcut to get food in.
Until they get stronger and tumor shrinks down and the radiation effects are gone. And
Yeah. And then we treat them with chemotherapy and radiation for the cancer up top. Yeah. And patients do so much better if they have a feeding tube in. Sometimes it's hard to convince them to get one, but it's so much easier on them.
Now, the bad part about the feeding tube part, since we started this discussion, is like today we got a consult for a 94-year-old patient who has dementia, has no quality of life. There is no future for her to become ambulatory or active part or anything.
Yeah.
She is sort of checked out, and the family is insisting to have a feeding tube put in. Those are the dilemmas which becomes very difficult for us to handle sometimes, especially with the aging population.
And with dementia, you can pull the feeding tube out.
Absolutely.
And so there's some risk.
There's more risk. I mean, especially doing any procedure or anybody who's octogenarian or
80-year-old or
I mean, above, it just risks are high and people don't understand.
Yeah.
That so it's difficult to sometimes, and we become the person in the middle of all of that.
Yeah, and you have to navigate
solution.
that very delicately.
Very, very delicately, because you can make a lot of people unhappy.
Yeah. So in the cancer world, one thing we've seen is that younger people below the age of 50 have had an increase in the incidence of rectal cancer and colon cancer. What do you think is causing that?
Doc Discussions with Dr. Jason Edwards, brought to you by St. Luke's, St. Louis.
Well, so we really don't know. The risk factor for colon cancer include obesity, increase in animal products, of course, family history. But we really, I think so. One of the reasons I think so we may be discovering more because we start screening at 45 years of age now.
Sure.
So once you start screening, you're going to discover more also.
Yeah.
So there are a lot of factors. I don't think there's one factor which gives you the best answer for that, but it's a multiple factor. I mean, it is second most commonest cancer.
Yeah.
In the world, and so it is out there. We just have to be aware of it, be proactive in getting a screening done and all that. And
they've recently changed the guidelines from getting a colonoscopy at 50 down to age 45.
45, almost, 1.5, 2 years now.
And the main symptom...
That has increased our workload also.
Yeah.
And so that's why majority of gastroenterologists are quite busy.
Yeah. But you still have all your hair, and most of it's not gray. And so, and so the main symptom patients have with colon or rectal cancer, what is that?
Well, so once you start having symptoms, that is sort of late.
Yeah.
Still, the outcome is pretty good.
And what's the first symptom people typically have?
So, I mean, somebody can have just rectal bleeding.
Yeah.
So bleeding would be probably one of the most commonest thing.
Yeah.
If it comes to abdominal pain, then things have grown.
Yeah.
Things have grown that it's affecting you and causing pain. Anemia, iron deficiency anemia, weight loss. But rectal bleeding, I would say, or change in bowel habit.
Yeah.
More constipation, more diarrhea, and things like that.
Yeah.
I think if people have family history, they need to be more proactive. And if somebody's father has a colon cancer at the age of any first degree relative who has a colon cancer under the age of 60 is at high risk. And so those are the people who need to start their colonoscopy at the age of 40. Having said that, if a first degree relative of a patient has a colon cancer at the age of 45, a first degree, then that person should have his first colonoscopy 10 years before that age.
Yeah. And you start to worry about genetic diseases like hereditary,
exactly,
non-polyposis.
So HNPCC, and so those are the things. So I think that it is one of the cancer we can really make a difference.
Yeah.
And a person can make a difference because it's not like pancreatic cancer. It is not like cholangiocarcinoma.
Yeah.
Or a brain tumor. This is where even if you are stage 3 cancer, your 5-year survival is not as bad.
Yeah, you more likely than not, you will be cured, even if it's stage 3.
And plus with the new immunotherapy on horizon. I think so the whole cancer game for solid tumors,
It's improving.
it's improving, and I'm hoping for more to come.
Yeah. Now, I'm going to switch gears a little bit and talk about you personally. This is audio, so people can't see, but you're to me, a very healthy guy. And you've got great hair too. I have no hair. You have great hair. Life's not fair. But you've got, and so I would imagine your diet is pretty good. Is that accurate? I mean, I'm sure you sin every now and then, but
right. Yeah,
pretty
so
good.
regular 5-6 days a week. I mean, we eat at home. It's not like we have to go out.
Yeah.
We cook at home and we eat at home, and so that's like everyday thing.
Now, are you vegetarian?
No, I'm not.
Okay. No. You eat some meat or a lot of meat?
I eat majority of the meat except for pork or ham.
But like, what percentage of your diet is meat versus like fruits, vegetables, things like that?
20%.
You'd say 20%.
20%.
It's not the staple of your diet.
No, 20%.
And that's I think that's more of kind of, my brother lives in Japan, and you see that more in Asia, where meat is on the plate to kind of flavor the plate, but it's not the main dish.
Yeah, it's not like a steak.
Yeah. And
we didn't grow up eating just steak.
Yeah, I grew up on a beef cattle farm, and so the steak was basically free. So every
meal was a steak meal.
Yeah,
we didn't have it.
We had grass-fed organic before it was cool.
Right. And other thing, I eat steak, I eat beef, but beef is not what I grew up with.
Yeah,
I grew up with chicken and goat.
Okay, yeah.
Chicken and goat meat, and still my favorite is goat meat.
Now
some people grew up in Arab world, grew up on lamb.
Yeah.
And so lamb becomes their thing. Beef was not something we ate a lot when we were growing up. Now in US, when you're eating steak, it's a beef steak. So
Sure.
But it's still, we don't bring beef home to cook in our diets.
Got you.
I mean, we eat it, but we don't bring it home on a frequent basis, I would say.
So we also had goats and on our farm.
Is that right?
And one thing that I'm totally off subject here, but we had this trailer that would the flatbed trailer out in our field, and it was like the tallest thing in the field. And if you went and stood on the trailer, the goat would come and try to push you off. And as a boy, that's a lot of fun, wrestling with the goat up there. But
what was the purpose of goat on that farm? Were you guys eating?
Yeah, for sure.
Okay, so meat was consumed.
Yeah, beef cattle, and then some goats and chickens and the whole thing. And so I think that's a healthier diet. Like if you are going to have meat as a part of your diet, the data looks like you do better if you eat smaller portions of meat.
Exactly.
And
more plant-based.
Yeah.
I think so. Studies after studies are coming out now.
Yeah.
Regarding emphasis on plant-based diet, longevity data.
For sure.
I mean, so it's more plant-based diet. I mean, if you can switch to become a vegetarian, which I am not certainly.
Yeah.
Though on the other hand, I think so education is also important. I mean, you see a significant incidence of coronary artery disease and diabetes mellitus in countries like India, where there is a lot of vegetarian.
But they eat a lot of ghee or what is fat, lard.
Right, so they do eat ghee also. But again, at the end of the day, you need to know the glycemic value of certain even fruits and vegetable. Which vegetable has a high glycemic index?
Okay,
and if you consume more of most of those things, then your sugar is going to go up, and sugar is going to store as carbohydrate, and you're going to get fatty liver, and you're going to get coronary artery disease, and you're going to get diabetes.
And so let's go a little bit into the physiology of that. And so so you take in sugar, and your glucose level goes up because you're ingesting sugar, and then your insulin level goes up.
Yeah.
And insulin is a very powerful, probably more powerful than steroids at building muscle. But the problem with it is it indiscriminately puts builds muscle, fat. Muscle and fat. And so, which tends to be not healthy for you. So it's the insulin that can cause you trouble in a lot of this. And foods have a glycemic index that you can look it up, glycemic index for an apple or a Snickers bar.
Right.
But they have something called the glycemic load too, which is, in my opinion,
How quickly it goes.
that tells you how high does the insulin go, because the fiber in fruit will actually blunt the insulin effect. And so an apple actually doesn't have that high of a glycemic load because there's so much fiber in it. And so I think, for me, when I look at foods, if I want to eat low glycemic foods, I think almost the glycemic load kind of gives you a better real world view of what's good and what's bad. And so it's not for the listener out there, it's not a bad thing to Google like glycemic load and get a list of foods.
It's all out there.
Yeah.
My wife gave me a watermelon juice the other day.
Okay.
And she brought it in and she made it, and it was tasty and very good and beautiful color of watermelon. And I had it, and I said, this was a big sugar load.
Yeah, for sure.
It was a bit. So her argument was, well, there are some vitamins in it also. I said, I think the advantage you are getting from the vitamin is much less than the sugar you're giving me. So we had this discussion about these things. So a lot of people will say, fruits have more vitamins and all that. You get those two, like orange juice. Now, orange juice is sugar.
Yeah.
To me, it is sugar. It is not indicated for people who have diabetes or anything. So you need to understand that. But yes, it has vitamin C in it.
Yeah.
All citrus fruit have vitamin C in it. But if you start drinking a glass of orange juice every day and your diabetes is not well controlled and you are overweight, then this is where the problem, and you have bad acid reflux at the top of it.
Yeah.
Then you are in.
Yeah. So, orange juice, not exactly health food.
Right. But I mean, we all grew up
with the concept
of eating cereals in the morning.
Sure.
Which is nothing but sugar. We loved it.
Yeah.
We all loved it. I still like it.
Yeah.
But there are a bunch of sugars in it.
For sure.
I mean, but now I think so the awareness is coming on. But as a kid, hey, if I'm hungry, let's go have some cereal.
For sure. And you can find some that are healthier than others.
But majority the one which we liked.
Yeah, the Captain Crunch with this. Yeah, for sure.
Those were the sweeter ones.
That's the best.
Yeah. They were the best.
Yeah. Kid approved.
Kid approved. So I tell my patient who comes in and says struggling with the weight loss and everything, and especially with people who are pre-diabetic or diabetic.
Yeah.
I tell them anything which looks good or tastes good has sugar in it.
Yeah. And I think if you want something sweet, at least eat the whole fruit.
Yeah.
Your body was actually meant to take in the fruit that looks like it came off of a tree. You can take that in. And the glycemic load's not that high because of the fiber. But when you crush it in a press and take all the sugar and leave all the fiber, then not so good.
No, then you got more sugar than anything else.
Yeah. And sometimes the fructose can even be harder on the liver than the glucose, but I wouldn't intentionally try to. So I think eating the whole fruit is very reasonable, and having a smoothie or something like that has some sweetness to it is reasonable, just because the fiber not only blunts the insulin effect but also helps pull the cholesterol out of the blood.
Right, and I think so. You can get away with anything, and our forefathers did got away with everything, but they worked very hard physically.
Yeah,
I mean the kind of lifestyle we have now. And we're going to be couch potato and do nothing and no exercise and no physical activity, then it's a problem.
That's a great point.
You can drink a glass of grease, but if you have plowed all day in a field, then you burned it.
If the furnace is hot enough, anything will burn, right?
Yes. I mean, you just have to burn it. If you're not burning it, then it's going to just keep on slowly accumulating and...
Yeah. Yeah, if you slightly sin, but every day it compounds just like your 401k.
Yeah.
And so skeletal muscle, the nice thing about muscle is there's a GLUT4 transporter that takes, it's an insulin independent uptake of glucose. And so it's like a sink where it just takes the glucose out of the bloodstream. And so if you're working hard and working that muscle, it takes up the sugar well. And that's why, grandpa could eat a little bit more liberally than me and you.
Yes.
And so,
yes.
Well, Sajid, it's always good spending time with you. And I think, I know, talking about the diet and trying to give people good and accurate information about the diet is one of the things that we can make our community healthier. Probably the thing.
Absolutely.
Yeah.
And decrease disease burden, cost effective, economic improvement, and everything.
Increase length of life, increase quality of life.
Right,
it doesn't really get, as far as health goes, more important than that in preventing disease.
Yep.
Well, buddy, thanks for sharing time.
Thank you for having me.
Yeah. And to the listener, please tune in next time. We appreciate you.
All right. Thank you.
Join us next time for Doc Discussions with Dr. Jason Edwards. It's medicine for your body, mind, and spirit.